management. And unfortunately, it is less often discussed in most of the conferences. However, with the advent of the new drugs, for pulmonary hypertension, there has been a sea change in its treatment and management strategies. Now, Dr. BP Pandey, an old friend of mine, is a very knowledgeable and astute cardiologist. And after passing MBBS from Calcutta Medical College, he did his MD from Maulana Azad Medical College and his DM from GB Pant Medical College, New Delhi. As you know, he's currently the head of the Department Cardiology of Narayana Super Specialty Hospital, Howrah. I will now invite, yes, Dr. Pandey, to share your screen, and could you please give your talk, which is on an approach to pulmonary hypertension.
Pandey, unmute karo. Pandey, unmute yourself.
Yeah, the slide also would have to move to the first one. Okay.
Pandey, তুমি স্ক্রিন শেয়ার করো।
হ্যাঁ।
Just give me a I hope I'm audible now, Shubhra.
Yes, you are audible.
What I propose, I'll give some clinical inputs before shifting gears. So as Dr. Shubhra Banerjee said, it's very difficult to diagnose pulmonary hypertension unless you have an intuition to diagnose. And who will treat these patients? It is from the general physician to cardiologist to chest specialist. And with the advent of intervention, I think management of pulmonary hypertension has moved from interventional cardiologist to mostly a chest physician. In fact, that is the practice in our hospital we are following. If you get particularly this group 1 of pulmonary hypertension, I'll come back to the classification that usually refer to the chest physicians. So group 1 will discuss in detail what are the subsets. In our MBBS days, these were called as a primary pulmonary hypertension. Group 2 is because of the left heart disease. So pulmonary hypertension resulting from left heart disease will usually be managed by we people, cardiologists. Whereas the group 3, where the pulmonary hypertension is because of the hypoxia or the lung cause, is usually dealt by the chest physicians. Whereas the group 4, which is a very treatable sort of pulmonary hypertension, which is known as a chronic thromboembolic pulmonary hypertension, this is once again dealt with mostly by the cardiologist and cardiac surgeon, and group 5 belongs to anybody. So that's a basic schema, and this WHO classification is very interesting, and we will usually follow this scheme during our next presentation. What is pulmonary hypertension? Once again, if we go back to our MBBS days, it is started with the mean pulmonary artery pressure of more than 25. Gradually, it has come down to a mean pulmonary artery pressure of more than 20. There is a logic behind that. Because in the normal population, most of the time, your pulmonary artery mean pressure hovers around 14 millimeter mercury plus minus 3. If that being the normal, and if you take a 2 standard deviation above that, in majority of the cases, it will always be below 20. So what we call 99th percentile above is cutoff is 20, and 25 was taken so that we do not overdiagnose pulmonary hypertension and give them unnecessary treatment. Another thing, you have to look at the pulmonary wedge pressure before you level it as idiopathic pulmonary hypertension, whether this is from the left heart diseases. So if wedge pressure is more, mean pulmonary artery pressure is more, most likely this is post-capillary and deals with the left heart causes. And nowadays, the importance of measuring pulmonary vascular resistance has also come. We'll discuss when we discuss the treatment. So in nutshell, I can tell you, if you get a pulmonary hypertension diagnosis, you have to establish two things: mean pulmonary artery pressure more than 20. And this is very important. By what means you will assess this mean pulmonary artery pressure? I'm coming to that. So coming to the this World Society of Pulmonary Hypertension Task Force recommendation, we have to be more aggressive in certain high-risk population, particularly the HIV, particularly with the cirrhotic, particularly with the congenital heart disease, particularly those who have undergone Fontan and other reparative surgeries, because it has a direct bearing with the outcomes. So here we have to be more aggressive, and I missed out the collagen vascular disease, particularly the scleroderma, where PH screening program is done every yearly. So active screening program will let you diagnose early, particularly in scleroderma, and thereby you might prolong the survival. So how we can diagnose pulmonary hypertension in our day-to-day practice? As I said, symptoms are very vague because we are tuned and we are taught in such a way that our brain tabulates 1 + 1 is equal to 2, 2 + 2 is equal to 4. So majority of the time, if patients are not falling into that category, we tend to miss the diagnosis. And we have also seen patients being referred to psychiatrists for complaining of undue shortness of breath and fatigability because somehow echo was done, which was normal, X-ray was missed, because signs of pulmonary hypertension in the mild to moderate grade is not that great to catch the eyeball in your PG chamber practice. So unless you have a intuition to diagnose someone who complains of a shortness of breath, lethargy, getting chest heaviness on exertion, sometimes pre-syncopal, you might miss it unless it is to the stage of very severe pulmonary hypertension where anybody will pick up. Second is the more progressive disease. This is one of the progressive diseases which are sometimes missed, and if you miss, a prognosis is going to be worse. It has to be supported by signs of right heart pressure overload and ultimately right heart failure. So these are in nutshell some clue where you will be able to think whether this patient is suffering from pulmonary hypertension. So what are the commonest symptoms in most of the registries? The two registry I have shown here. One is NIH registry and another is the Reveal. The commonest symptom is dyspnea on exertion, whereas all other, they are much way down. And syncope is another very not so uncommon. We see in 1/3 of the cases a patient landing with syncope, and your other investigations are neuro evaluation, other cardiac evaluations may not reveal it so easily. So the commonest symptoms once again is a shortness of breath and fatigue. And the two important tests which comes to our rescue is EKG and echocardiogram. EKG is not that sensitive unless you have got a very significant pulmonary hypertension. You may not get RV hypertrophy and right axis deviation or pressure overload, but echo will give you a very early clue. What are the findings we look? Of course, for diagnosis, we need to estimate pulmonary artery systolic pressure. If your echo has some amount of tricuspid regurgitation, there are ways to have a better look just by adjusting the gain and the Nyquist limit. You will be able to get some amount of TR in more than 70% of the cases, and you will pick up on continuous wave Doppler TR gradient. So measuring the TR gradient and addition of RA pressure will give you a systolic artery pressure. But if you are not having a tricuspid regurgitation, there are other ways to measure pulmonary artery pressure by looking at the pulse Doppler at the pulmonary valve level. We're looking at the pulmonary acceleration time, and there is a formula to diagnose that. There are some other signs, particularly we discuss in our pulmonary embolism cases, rule of 60 and 60, meaning thereby you have a pulmonary acceleration time which is below 60, as well as PA pressure below 60, usually tends to diagnose PH in thromboembolism category of patient. So measurement of PA pressure is crucial. If you cannot, still you have a very high suspicion. These are the patients we need to go for right heart catheterization. And anyway, for group 1 pulmonary hypertension, anyway, we need right heart catheterization, we'll discuss. So on echo, looking at the PA pressure, looking at the RV hypertrophy, looking at the size of RA and RV, and of course, the signs of RV dysfunction will tell you something. So this is the differentiation, how we can have some clue on echo, whether this pulmonary hypertension is because of the left-sided heart disease or per se because of the idiopathic pulmonary hypertension. The measurement of LA size and tissue Doppler velocity will be able to give you some clue. So once if you are not very familiar with echo, I'll always suggest have a talk with echocardiographer and give them some advance what you are suspecting, so that he can have a better look at that particular patients. And even at this age, sometimes we are liable to miss pulmonary hypertension, because if you do a cursory examination and you find mitral tricuspid flows are normal, there's no hypertrophy, normal LV-RV function. So if your mind doesn't know, you might miss pulmonary hypertension altogether. So it is very important that you diagnose pulmonary hypertension and then you proceed thereon. Further test will depend on when we try to analyze what is the etiological diagnosis. And that includes the pulmonary function test, VQ scan. So these are all in the domain of chest physicians. I do not understand to that extent, but it's team work, both from a cardiologist and chest physician. And after we have ruled out left heart causes and congenital heart disease, in majority of the cases, they are referred to a chest colleague. There will be certain blood tests which will be important, and these are for etiological diagnosis, like doing workup for collagen vascular disease, thyroid disorders, liver disease, as well as looking for a screening for HIV and hepatitis. These are all important blood investigations. Another important test is looking at the 6-minute walk test. This is not only important to assess the symptoms, but also how it behaves at the end of the therapy. So we have a follow-up categorization based on 6-minute walk test, and most of the drug, which I'll discuss later on, this will come up frequently. Whether we need right heart catheterization in majority of the cases, answer is yes. Whether you want to diagnose a group 1 of PH or you want to diagnose a group 2, that is the left heart cause, or we want to diagnose from the lung cause, in majority of the cases, we need right heart catheterization. The reason is that measurement of pulmonary pressure by echo is not so accurate. Just to give you a clue, that almost 10 millimeter overestimation we do on echo. So unless you are very dedicated echocardiographer, because these things are so much dependent on the preload and afterload. Someone who has got a very high output, you may overestimate TR gradient. Someone who has got anemia, you will overestimate. Someone who has got a thyroid disorder, you might overestimate. So cutoff for echo of what we call is 40 millimeter RV systolic pressure. So if you get 40 onwards, then we try to assess the mean pulmonary artery pressure by doing cardiac cath. Mean pulmonary pressure can also be delineated by a Doppler interrogation of the pulmonary valve level, but usually this is a diagnosis on cardiac cath. So on cardiac cath, what we look? We look at the PA pressure, both systolic, diastolic, and mean. Look at the RA pressure, look at the wedge or LVEDP, and Then you calculate on oximetry what is the cardiac output, cardiac index, what is the PVR and SVR. So that will give you most of the diagnosis. Saturation measurement is also important because we'll discuss the vasoreactivity, whether this pulmonary hypertension responds to oxygen therapy, because we don't do a nitric oxide vasoreactivity test in our lab. Mostly we resort to a high flow oxygen, and sometimes we give some vasodilators. We'll discuss, but normally we do not do nitric oxide vasoreactivity in our cath lab. So right heart catheterization is important. So just to summarize on the clinical part of the pulmonary hypertension, there have to have a high index of suspicion, thorough investigation that includes ECG, echo, lung function test, and few basic blood examinations, has to be confirmed in majority of the cases with a right heart catheterization, particularly if you want to go to the triple therapy or a dual therapy in an idiopathic group of patients. And of course, the 6-minute walk test, looking at the HRCT, looking at the MRI sometimes to find out the etiological diagnosis, ultrasound, abdomen. So these are the things which will be important. So coming to the PH-directed therapies, the basic framework I will tell you. Suppose you are able to now exclude this is not because of the left-sided cardiac disease. This is not because of the COPD. You have done a VQ match or a CTPA pulmonary angiogram to rule out a thrombopulmonary embolic cause of PAH. So we have restricted our diagnosis to an idiopathic, or what used to be called as a primary pulmonary hypertension in the past. So targets for current therapy in idiopathic PH, which is our various subtypes, there are 3 pathways which we can use. So the most common to begin with, we used to have a phosphodiesterase pathway inhibitors, usually sildenafil or nowadays tadalafil. And then was the endothelin pathway. To begin with, it was a bosentan, and now we have got a various ambrisentan, macitentan. So on endothelin pathway, and of course in sicker patients, the prostacyclin pathway, both injectable, intravenous, subcut, nasal. There are various formulations. So these are the basic 3 pathways. And in majority of the cases, we'll probably go with the dual pathway, if not triple, depending on the severity of the disease. So most of the drugs like sildenafil, tadalafil, ambrisentan, macitentan, bosentan, they are all available in our Indian market. We have to look for riociguat and a prostacyclin injectable only in dedicated hospitals, not freely available. Even macitentan is not easily available over the counter. You have to search where it is available. But sildenafil, bosentan, and ambrisentan is most widely available in majority of the counters nowadays. So the target is, we'll discuss how we plan our treatment. So these are the classes of the drug, and most of the drugs are FDA approved nowadays. So we have got some experience we'll discuss. So how the treatment has evolved over several years nowadays. And we have found that if you start these combination therapies, symptomatically patient starts getting better, their walk distance starts improving. And of course, the PA pressure also comes down after 5 to 6 months of therapy. Right heart failure comes down. So he gets much symptomatically better in at least 60 to 70% of the cases. We have to also look at the side effect profile, particularly the phosphodiesterase 5 group of inhibitors and endothelin receptor antagonists, fluid retention, persistent headache, sometimes hemoptysis. These few are very common side effects. So you have to keep on watching for the side effects. Coming to the treatment approaches. So these are the 2018 World Symposium, which I was alluding to the first slide. So that those who are treatment naive patients, So what we do once we have confirmed the pulmonary hypertension on cardiac cath, we do a vasoreactivity test, mostly by giving high flow oxygen, although the recommendation is give nitric oxide and show that there is a drop in 10 millimeter of mean pulmonary artery pressure, as well as absolute pressure should come down below 40. These are the group of patients who will respond to calcium channel blockers. Out of total group of patients, at least 10 to 15% will belong to these calcium channel blocker responsive. So the vasoreactivity test is important. So those patients who are not reactive, and that is the majority of the cases, we classify them into various risk categorization, whether they belong to low or intermediate group, or they belong to the high risk group. There are various scores. Usually we follow the REVEALS 2.0 score. That is the 2015 European guidelines scores. So we have some form get tuned to one scoring system so that you can classify your patient whether they belong to high risk or they belong to intermediate risk, and then decide on the therapy. For the high risk group, it is very important that we'll probably start with the double, if not triple. It's usually a combination of either ambrisentan, tadalafil, plus minus IV prostacyclins, or instead of ambrisentan, we can have a macitentan, which is a latest kid on the block, side effect profile, and we continue the therapy. The only few selected group of patients, around 10 to 15%, we will be having only monotherapy because they fall into the lowest possible risk category. So in majority of the cases, it is double, if not triple therapy. Even if they do not respond, how do we assess them? Whether they are moving back to the lower functional class, whether 6-minute walk test is getting down, whether his pro-BNPs are coming down. If not so, we escalate our therapy, and probably some interventional therapies will be done while they are waiting for lung transplant, like decompressing the right heart by doing a shunt devices, or we can directly enroll them for a heart-lung transplantation. So majority of the cases in our practice, we go up to the is done. No lung transplantation has been done so far. There are a few centers in the south who are doing it. So this is the basic algorithm for treating idiopathic pulmonary hypertension, which is the most common. So there are certain special subgroups in idiopathic, particularly the hereditary variety, where we need to do some genetic markers, whether they belong to those polymorphism, or they are because of some anti-obesity drugs. So there are various anti-cancer drugs nowadays, also particularly those used in HIVs and few oncohematologic malignancies, which may also cause pulmonary hypertension. So this is all belongs to the same. Important addition of anticoagulation is also important along with diuretics in idiopathic pulmonary hypertension. And the anticoagulation usually preferred is a warfarin and not the NOACs. And the second subgroup, a special subgroup, which is important, is the left-sided, and because of the COPD. It is important to remind you that these pulmonary hypertensive drugs are not useful if you have a PS because of the left-sided heart disease or because of the, say, COPD or congenital heart disease. But we do see a common practice pattern, people using sildenafil and tadalafil, that causes usually harm than good. So unless very selected cases, we usually do not treat pulmonary hypertension if it belongs to grade 2 and grade 3. Whereas the chronic thrombopulmonary embolism, we have got a very large series from our NH Bangalore. And this is one of the very rewarding treatment. So the index of suspicion, how to diagnose a chronic thrombopulmonary embolism, should be high because this is the treatable one. And just you have to do a VQ testing, ventilation, perfusion, along with the pulmonary CT pulmonary angiography, and will cleanse the diagnosis that this is a chronic thrombopulmonary embolism, and they will be subjected to endarterectomy in advanced centers. Not every surgeon does it, but those who do it, they get very good outcome. So how do you assess the prognosis in these patients? This is important. So it's always clinical, whether the functional class is improving, whether the 6-minute walk test is coming better and better, whether they are able to walk more than 440 meters. Look at the blood markers, particularly the NT-proBNPs and troponins. So these are the important parameters, and of course, we'll show you the various RV functions like TAPC getting better, the IVC getting better, the tissue Doppler velocities of the RV annulus is getting better. So there are echo parameters also we can find out whether they are improving, and these are very objective one. And as I said, there are various risk predicting models. Mostly we use a REVEAL or 2015 ESC guidelines to categorize the patient as well as to assess their response. So it's always a multiparametric imaging and multiparametric pathways for a risk assessment, not only clinical, biochemical, echo, 6-minute walk test, sometimes hemodynamic evaluation, and ultimately very few cases, if you are enrolling them for transplant, then usually we do a cardiopulmonary exercise test, or if they have a what we call group 3, that is because of the chest disease, then CPET is very important. So since the advent of heart transplant in our hospital, we are doing more and more CPET in our pulmonary hypertension patients. So it is important that you combine the CPET with the right heart catheterization to get accurate diagnosis, and later on follow their prognostic pathways. So goal is an improvement, not just the preservation. And we try to get it down most of the patient to the lowest risk category, which is not always possible because of the low systolic blood pressure. Most of the patients, we cannot adjudicate the doses to a maximum, which have been shown in the various trials. But we always try to make endeavor as far as we can treat the patients. And once the patient starts improving, always try to cut down the diuretics, because that will help you to up titrate the other disease modifying drugs. So the summary of the Shubhra, are you asking something? Okay. Assessing the pH risk scores. So these are the various registries, REVEAL registry, Swedish registry, the French Pulmonary Hypertension Network, and they all are important in understanding how do you define the low risk patient, how do you define the high risk or the intermediate, because that will help you to plan out the treatment with a double or a triple therapy. So in the current area, it is always combination 2, if not the 3, although these are the costly, but there is no other choices. So in majority of our practice, either we use the ambrisentan with tadalafil or macitentan with tadalafil. I do not have much experience with the prostacyclins. These are usually used either by chest physicians or sometimes by our pediatric cardiologists, because they deal with a lot of congenital and post-repair patients who has got significant pulmonary hypertension. So it is important that you characterize your patients and make a concerted effort. I'll tell you a few trials which have been done with the macitentan. One is the Serafin. Another molecule is selexipag, which is also FDA approved, is the Griffon trial. In last few years, a lot of things are coming which are actually in the molecular level, acting at the TNF alpha level. There are certain things which acts on other pathways. So people are going to the level of inflammatory markers, and at least 4 to 5 drugs are in pipeline to look at those molecules, just like we are doing in lipid therapies, a lot of silencing RNAs, TGF alpha, beta blocker. There are so many things which I am not too conversant, but I have gone through those papers. A lot of exciting things are coming up as a treatment. But only point of submission is that we need to diagnose pulmonary hypertension before we can embark upon these high things. So this was one of the slides where we can switch from sildenafil or tadalafil to riociguat in a stable pH. And this replaced trial had a 30-day primary endpoint. And this is negative trial. So in conclusion, I like to tell you that once a patient complains of shortness of breath and you are not getting any clue, you have ruled out probably ischemic heart disease, you have ruled out the medical causes, always try whether I'm missing the pulmonary hypertension, because sometimes, as I said, tricuspid registration is not there. An echocardiographer might miss it. ECG sometimes, unless it is very overly RV strain pattern right axis, you might miss. Sensitivity is not that great. So it boils down to echocardiogram, and in some cases, resorting to right heart catheterization to pick up the diagnosis. And in one extreme, a patient will come with the full-blown right heart failure, almost at the fag end of the disease. Then it is really difficult to control them, even with the most of the drugs, because of severe hypotension and anasarca. So these are the patients we only able to manage with the digoxin and diuretics and MRAs, and give them palliative treatment before listing them for transplant, if at all there is some program in your vicinity. So I think I'll stop here so that I can take few questions from the audience.
So thank you, Vijay. I think it was a wonderful, enlightening talk. And I would, there are a few questions actually in the chat box. So I think let's start with them, and I would also invite questions from others. I think the first question is from Dr. Shibendu Ghosh. Do we still avoid cardiac angiography in primary pulmonary hypertension?
Yeah, as I said, in our MD days, it was a relative contraindications. And I think nowadays it has come full circle. This is imperative to do right heart cath, not only for clinching diagnosis, but also excluding some other diseases where these drugs will not work. So unless you measure the pulmonary wedge pressure or LVEDP, or you measure the PVR, it will not be a complete workup. So short answer, in majority of the cases, we'll do cardiac cath, and this is quite safe.
Okay. No, I think we had a wonderful discussion, and there are a lot of things which has already been discussed. I do not have any further question, and unless any other list has a question, I think we may be able to conclude the session. It's a brilliant talk by Vijay, I would like to say once again.
Okay, thank you, Bijay and Shubro. Now I request Nandini Chatterjee, who is the editor-in-chief of our Bengal Physicians Journal from the API West Bengal branch. I request Nandini to give vote of thanks.
Thank you, sir. So the West Bengal Forum of ICP Fellows and API thanks Dr. Bijay Pandey for his beautiful lecture, and also Dr. Shubhro Banerjee for summing up and taking all the questions. I would also like to thank all the panelists who are present here and who have contributed in making this lecture more interactive. I thank all the students who have joined in, and I would request them that they should also tell their friends to join in, because these lectures ultimately are meant for their benefit. And our speakers like Dr. Pandey today, who had given such a beautiful way of approaching the diagnosis of the patient clinically, as well as with investigations on how we note the progress of the patient. So I'm again requesting the students to bring in your friends so that we have a fuller class. And lastly, I would like to thank all the conveners of this master class, and Professor Amal Banerjee, Professor S.B. Ganguly, and Professor H.S. Pathak for this master class. And thank you.
Thank you.
One small thing, if want